20-year-old female, comes from a group home. She comes into the ER also with an altered level of consciousness from her baseline. She's not acting herself. She had a very acute psychotic episode 2 days ago, and her regular dosages of neuroleptics was increased. She's usually on olanzapine. She has a history of schizophrenia, and this is her vitals. And as you can see, they don't differ too much from the initial vitals of case 1. Not too off. Maybe her GCS is a bit lower. Everything else is the same, and her initial temperature of presentation is a bit higher. Other than that, vitals-wise, she presents the same as case 1. Physical findings as well. She's sweating very profusely. She's got a very labile BP, goes up and down, up and down. No seizure-like activity or any focal neurological deficits that you can find. But she's got some very slow reflex as opposed to hyperreflexia. And she does have lots of rigidity in her muscles throughout, not just in the lower limbs. And obviously, medicine being medicine, nothing presents perfectly. But we're trying to make this sort of more textbookish than you usually would find. But that's what you see in case 2. So again, initial management is not going to differ too much from the initial management of case 1. And as always, you hold off giving medications unless you're pretty positive what's going on, because in this case, if you were to give certain medications, which we'll discuss, you may tip the iceberg towards a point where you don't want to go with the patient. So objectives of today's talk is essentially to keep the grand in the grand round, so hopefully make it beneficial for everybody here today, make it a little bit interactive, and hopefully impart some knowledge and pearls about the topics. And the topics are serotonin syndrome and neuroleptic malignant syndrome. And case number 1 was serotonin syndrome, and case number 2 was neuroleptic malignant syndrome. And we'll go over all those 2 with the focus on serotonin syndrome. So before we get into that, I just want to show of hands, if your hands are working this morning, about true or false. So serotonin syndrome, so true or false. You can just answer to yourself as well. So not a life-threatening condition associated with increased serotonergic activity in the CNS. What do you guys think? Is that true or false? Okay. Heard one person. Okay. The next question, solely associated with the SSRIs or SNRIs? Okay, and the majority of cases are due to overdose. False. Good, they're all false. And so we'll go into elaboration of that later on. Actually, next slide. So serotonin syndrome, it is a potentially life-threatening condition, and it is associated with increased serotonergic activity in the CNS, mainly, as well as the peripheral nervous system, and we'll get into that as well. And it's not due to any one drug. What essentially happens is that there's an increase in central serotonin neurotransmission, and that happens not just from SSRIs. It can happen from a multitude of drugs that we commonly prescribe, actually. And surprisingly so, it is only in 50% of the cases is it found to be due to an intentional overdose. Often results usually from therapeutic dosages, drug interactions, and a potentiation from a combination effect of using 2 or more serotonergic agents at the same time. So whenever a patient like this comes in, we may have the tendency to fixate on a history of depression or SSRI usage, but I would say we should caution away from that because it's going to limit our scope. And it may lead us down the wrong path just because the person's not on any SSRIs or has a history of any psychological issues. Psychiatric issues. So interestingly enough, I found on one of the journals that I was going through that 85% of physicians in one study in the UK were not even aware of serotonin syndrome being a presentation that can be found in an acute situation. They weren't even aware that drugs that increase serotonergic activity can lead to a finding of serotonin syndrome. So that was a bit shocking. So the classic pharmacology for this is that usually what happens is there's 2 or more simultaneously administered serotonergic agents that sort of act synergistically to create an increase in the neurotransmission of serotonin, and that leads to these effects that we see, and we'll get into the classical clinical presentation in a second. But what I wanted to emphasize is there's no correlation between what the serum drug levels are or the dosage change that occurs in medication that manifests into the syndrome. So there's no one test that we can do to find out if that's going to be indicative of that person having serotonin syndrome. It's purely a clinical diagnosis based on your history and your physical findings, and like we did together, deduce our way down from the presentation and try to figure out what may be going on. But there's no correlation between drug levels or any changes that recently may have occurred in the patient's pharmacology that would lead to this. So just to understand the symptoms and why they present in the way that they do, what happens is that, just if you go back to what serotonin does physiologically, it works in the CNS and the peripheral nervous system as well. And what it does is it modulates behavior centrally, and is also playing a part in thermoregulation. So that's one of the findings that we see in terms of, the person being febrile, acting sort of belligerent and uncooperative, having an altered level of consciousness. And then peripherally, what happens is that serotonin usually aids in vasoconstriction, as well as regulating the motility of the GI system. So that's why we get sometimes nausea, vomiting, diarrhea in serotonin syndrome. We also will get the hypertensive patient as well. And essentially it boils down to stimulation of the postsynaptic receptors of the serotonin 1A and 2A receptors. And that was pretty much proven by this. I've got our references here for those who are interested, but the study by Boyer here illustrate that as well. So just a little note on the SSRIs. Inherently, they're not a very toxic drug. I know that we assume, because the name of the syndrome, that maybe they're a large cause of it, and we've sort of discussed that right now preliminarily that it's not. But just to sort of analyze the SSRIs, they're not a very toxic drug, and it's usually the co-ingestants that are the culprits or tip the patient over. And SNRIs are actually more implicated in serotonin syndrome than SSRIs. The worst SSRI out of all of them is citalopram. It has the greatest potential for toxicity. So the neuromuscular hyperactivity, things to focus on, I would like to sort of emphasize the myoclonus and the hyperreflexia. Those two things will hopefully help to bring down and narrow down the differential. And these latter findings are more so in the lower extremities than upper extremities for some reason, which I wasn't able to find in the literature a good explanation as to why that has a predilection for the lower extremities. Myoclonus is almost exclusive to serotonin syndrome when compared to those other things that we mentioned on the differential. And here's just sort of a picture that I thought would be illustrative of serotonin syndrome here, and I wanted to sort of just focus on the lower extremities here. So if you're trying to narrow down your differential, I would focus on the lower extremity as well in terms of the hyperreflexia, anyclonus, tremors, rigidity, looking to rule things out if there's more so of these findings in the lower versus upper extremities. And I looked for something on YouTube on serotonin syndrome. I couldn't really find anything. I did find, apparently there's a Euro dance hit called Serotonin Syndrome. Yeah, by some DJ in Denmark. But I didn't want to play that here because it would have gone us into a weird trance mode. But I did find this, so I'll just pull this up. We'll just appreciate how the clonus looks like, and we'll get into the hyperreflection and the clonus. He'll show clonus, but it's not the greatest. Here, this slide's coming up after this one ends. It's an old tool. There's some clonus for you, if you can appreciate it. That's all I could find. So, going back here, what is clonus? So clonus is an involuntary series of muscle contractions and relaxations, usually due to upper motor neuron lesions, the common ones being common. And essentially what you want to see is an inducible, it can be inducible as well if it's not happening spontaneously, and it's usually inducible by initiating the reflex and needs to be sustained for 5 beats or more, as illustrated in the little video there. One finding that I was unaware of, actually, something called ocular clonus, and that's found in serotonin syndrome. And it's apparently a diagnostic sign, rarely seen in other conditions, and is manifested by rapid and equal movements of the eyes. And here you're thinking, what the hell is this? What are you talking about? Are you talking about nystagmus here? So the difference of nystagmus and clonus is that nystagmus, you have a slow and a fast phase, but apparently in ocular clonus, there is no slow phase. There's no facade of the movements of the eye. They're rapid. Either way you make them go. With your eye movements, as they follow your finger, the movements will be rapid. So in an acute situation, I don't think you're going to be looking for this. If the patient is stabilized, clearly you may have time to try to elucidate this. So physical findings, we touched upon all of these. This is usually due to the autonomic dysfunction, and so I won't sort of belabor the point here. But just to highlight some of the confusing aspects that may tilt us towards a sort of anticholinergic picture is sort of dilated pupils, a dry mucous membrane, increased bowel sounds, flushed skin. So, but in this situation, the patient will be sort of more diaphoretic as opposed to dry. They will have dilated pupils in serotonin syndrome as opposed to NMS. NMS, they do not get dilated pupils. So just some things to touch upon here. Neuro exam, things I mentioned before, focus on the myoclonus, the clonus and the hyperreflexia. And if you're really good, the ocular clonus, even if it even exists. I've never seen it. So high diagnosis, as I said, it's kind of out there, it's difficult. You work with the history and your physical examination and try to deduce what's going on here. Luckily, there's a toxicology department in Australia called Hunter, the Hunter Toxicology Clinic. And they did an awesome study back in 2002. They had enrolled patients from 1987 to 2002, and they had, I think, about 2,500 patients that fit the criteria of serotonin syndrome. And so they went down to sort of elicit what kind of criteria they would have to fit into a nice sort of flow chart to figure out if they have serotonin syndrome or not, as compared to the gold standard of a medical toxicologist's review of the patient thereafter, obviously not in an acute setting. Prior to all this, they used the Sternbach Criteria, and that was sort of really prevalent in the 1990s. I was told that nobody in this room is over the age of 38, so maybe nobody knows about Sternbach Criteria, but we're going to focus on the Hunter toxicity criteria here because it's shown to be 84% sensitive as compared to Sternbach's criteria, which was 75% sensitive. And this is 97% specific as compared to Sternbach criteria, which is 96% specific. So this has been shown to be a better way of figuring things out with respect to a patient. So here's how it works. The patient must have taken a serotonergic agent and met one of the following conditions in a flow diagram, and here's the flow diagram. So you find out that they've recently had a serotonergic agent in the last 5 weeks, regardless of what it is, as long as it's serotonergic. So remember, don't focus on just the antidepressants. And then if it's no, then there's no option of having serotonergic syndrome. If there is, then you can move down this list here. And so if they have any of the following symptoms, so you just have to have one of these boxes, and then they're diagnosed with serotonin syndrome, so just one of them. So tremor and hyperreflexia, any sort of spontaneous clonus that you can appreciate when they present, any muscle rigidity, a temperature greater than 38, and either ocular clonus or inducible clonus, ocular clonus and either agitation or diaphoresis, inducible clonus and either agitation or diaphoresis. So as you can see here, clonus is a big thing. So that helps to differentiate between this and NMS and other things on a differential. I made up this mnemonic myself, actually, so I've already trademarked it, just to help us figure out if this is serotonin syndrome or not. So is the patient hot? Not just with regards to the temperature or physical features, but with respect to how the patient is presenting. So they already have serotonergic agents recently in the past, and then one of the following things on the mnemonic. Is it inducible clonus and agitation or diaphoresis? S, do they have any spontaneous clonus? Then you're done. You're good to go. H, hypertonia. As I mentioned, the O, ocular clonus and agitation diaphoresis. So not just ocular clonus. Don't just say like, oh, I see ocular clonus, serotonin syndrome. That's it. No. So there's got to be another thing going on as well, which is agitation or diaphoresis. And then T, and the two T's are there. Pretty straightforward. So is the patient hot? Don't forget that mnemonic. I'd be more than happy to give this presentation to anybody who'd want it. And also, Susan would have a copy of it as well. And if you're interested in the references, they're all throughout the presentation, which I could provide as well. So this is the Sternbach criteria. I'm not going to get into it. The problem with it was that it was very vague, and it really emphasized mental status changes, as opposed to just focusing on the clonus and the hyperreflexia, which they found in the Hunter study. So it's sort of fallen on the wayside here. And here it was in its original description, just for reference purposes and purposes of completion. Lab evaluations, and we touched upon a lot of them. Again, serotonin syndrome is a clinical diagnosis. That's the one thing I wanted to get across today. And as the Hunter criteria is illustrated, it helps us to appreciate. Again, serotonin concentration does not correlate with any clinical findings. No lab test will help to confirm the diagnosis, but some non-specific things that may help us in a differential, and a lot of these things were mentioned initially. We obviously do the glucose if the patient is a female or she's pregnant, do a tox screen, ECG, looking for any QTc prolongation or anything else that we're worried about in terms of ECG findings, and an elevated white blood cell count, CK, all this kind of stuff that we're worried about in terms of sepsis and other things on a differential that we initially presented. And we mentioned all these things, which is very heartening for me. I can sleep at night if I was ever to come in here and we would get all this stuff ordered on me. It'd be great. So management, this is very important. Management is what we want to talk about. This is what we're sort of paid to do. So the first three things are very, very basic, and essentially the things that we need to sort of discuss in our own minds with ourselves when the patient comes in, if we're assuming that they have serotonin syndrome, and that is DC, obviously all serotonergic agents. That's the first priority. Second priority, probably going to be obviously in congruence with the first one, is to give any supportive care, and that goes without saying, ABCs and aiming to normalize the vitals through fluids, etc. And at the extreme ends, if they're very febrile, looking at RSI as a way to not only paralyze them and then obviously sedate them if they're very belligerent as well. So we always obviously have that in the back of our heads as well. And then if they're not to an extreme where they need to be having RSI done to them, then we can try to sedate them with benzos. And we'll break this down in a bit in the next few slides. And then in extreme cases with very severe elevations of temperature, patients in extremities, we can consider giving serotonin antagonists, and we'll discuss that as well. And then this is not really relevant to any of us necessarily in terms of the ER assessment of the need to resume their serotonergic agents, especially when we balance the risk and benefits in terms of depression or et cetera. Then we'd have to revisit this issue once they've passed out their period of serotonin syndrome. But I don't think we'll be interested in that today. The severity of the illness is what dictates the intensity of the adherence to these principles. But the first three I think we can all agree on will be things that we should definitely try to start at least. Again, so we're breaking this all down. The supportive care standard is the following. So if they present within the first 2 hours and we're convinced that solely it's an SSRI issue and there's no contraindications to charcoal, we can give that. And then you want to resuscitate them with fluids and try to normalize their vitals. And like as I mentioned, if they need to be sedated with benzos, we can do that. 0.5 to 1 milligrams of lorazepam is a good way to start and titrate to effect. And just be cautious that the BP may fluctuate. But that may be expected. For their autonomic instability, if they have severe hypertension and extreme tachycardic, we can try to use short-acting antihypertensive agents like esmolol or nitroprusside. Avoid the longer-acting agents. And one thing I wanted to mention was that avoiding any indirect agents. So if they're very hypotensive and you want to bring their blood pressure up, it's suggested from the literature that direct sympathomimetic amines be used as opposed to any indirect agents such as dopamine. Because if there is an issue of monoamine oxidase inhibitor usage there as a cause of the serotonin syndrome, then there will be a delay in the metabolization of epinephrine and norepinephrine from the dopamine, and that will lead to sort of an exaggerated hemodynamic response and not ideal. You want to go for the direct agents, and that will be the ones that we hopefully would prefer to use as opposed to dopamine. So just if they're hypotensive in that situation, just to keep there in our back of our heads there. For the hyperthermia, there's no role for there's no role for acetaminophen at all, because the issue is not related to the hypothalamus. It's more due to the issues that are caused by the hyperreflexia and the clonus that leads to elevation of temperature, and so we need to go to the base of the cause. So like I mentioned, if they're very, very febrile and they're in extremitis, we can use paralyzation techniques through RSI, avoiding succinylcholine in those patients. Again, obviously we all know if there's a question of possible hyperkalemia, and that will hopefully do the trick. Now, I just want to discuss the antidote, specifically cyproheptadine. It's a histamine 1 receptor antagonist with non-specific serotonin 1A and serotonin 2A antagonistic properties. And it's used only if benzos and supportive care fail as a first-line agent to improve the patient's agitation and vital signs, or if they present right away in extremities to you. So that's what the literature says is a possible option to use as an antidote. I'm not going to get into the pharmacology of things in terms of the uses of it. Unfortunately, the only thing is that it doesn't come in IV or IM. It only comes in oral form, liquid and tablets. And so at this stage, considering it might be a way to get them through the NG tube, especially if obviously if they're intubated, would be a preferred way to go about doing this. But if you use the RSI, then generally you won't have a need for using these unless Dave has a different experience to recommend based on that. Again, when they're in the wards, it's not going to be our headache, but if they responded to this, they can continue to use this for up to 7 days. So the literature that supported this was, again, like in most tox literature, it's not sort of in comprehensive studies. It's more sort of anecdotal, and this is where the study. This is the study that sort of recommended, sort of supported the usage, of cyproheptadine. There is definitive evidence. Definitive evidence is lacking, like I mentioned, in most tox cases, and so this is the study that was done by Kapoor and al. And what they did was they used PET scans on just 2 volunteers to assess the serotonin blockade after giving cyproheptadine, and they found that it's quite effective in reversal of this. So whatever that's worth, I just wanted to bring that up. Other antidotes that can be used are other antipsychotics with serotonin antagonist activity, such as olanzapine. Not very effective. Chlorpromazine is one option as well, but because of the dopamine blockage, it's going to lead to extreme muscle rigidity and may exacerbate NMS if that's what you're dealing with and we went down the wrong path. So just to be wary of that. Things to never use, and I was glad that nobody brought this up, was bromocriptine, because bromocriptine can be potentially used in NMS if the case warrants it enough, if it's severe enough. But in serotonin syndrome, because it's a serotonin agonist, you're going to worsen the clinical symptoms of the patient. So don't do that. And propranolol, as I mentioned, long-acting beta blocker, not to be used because it can prolong hypotension and mask any tachycardia that may present later on in the patient's clinical picture. And dantrolene, again, not proven effect, and we just give that to make ourselves feel better. Disposition, this is important. Severe cases obviously need to go to the ICU. Moderate symptoms, admit and observe in terms of their vitals and any physical findings. Mild symptoms, I don't think any of us would do this, but discharge after 4 to 6 hours of the observation if there's no clonus and the vital signs remain normal. And they've promised not to take the agents that caused the initial syndrome to present. Bad outcomes. 25% of patients with serotonin syndrome end up getting tubed with ventilator support. There's only an 11% mortality, well, not only, there's an 11% mortality rate, and usually it's the ones that present very severely initially. And the issues that are considered severe are the hyperthermia and the hypotension. So again, very difficult to initially deal with because you might be thinking this is a septic patient or something else is going on, but if you follow the Hunter criteria, hopefully it'll help you to nail the diagnosis. Common pitfalls that clinicians have been found to experience with serotonin syndrome is a failure to recognize serotonin syndrome, obviously. Misdiagnosis, unfortunately, it's not an easy thing. not able to appreciate the rapid deterioration that can be found in a patient with serotonin syndrome. And they initially present very sort of benign and then start to tank very, very, very quickly. Giving serotonergic agents such as bromocriptine when the diagnosis is uncertain. Giving drugs with longer half-lives may unfortunately lead to prolongation of symptoms. And not getting advice from poison control. And the protocol that I mentioned in terms of management is also something that's been advocated by the Ontario Poison Control when I called them up to sort of verify where they stand. And they concurred with the findings that I had found from the literature. They didn't waver from that protocol for serotonin syndrome. Just a prelude, a pause before we discuss briefly NMS. It's not the focus of today's presentation, but I did want to discuss it in a little bit detail because serotonin syndrome and NMS are often confused with each other. So NMS is also a life-threatening neurological emergency due to neuroleptic agents, and unfortunately it presents somewhat similar to serotonin syndrome, and we've all heard the mnemonic PHARM, fever, autonomic dysfunction, rigidity, and mental status changes. And so that's what's found in NMS as well. But the rigidity apparently is more pronounced in NMS as opposed to serotonin syndrome. And the medications that cause NMS are often obviously very different from serotonin syndrome. They're usually the typical or atypical neuroleptics, and some of the lower potency ones as well. One of the most common antiemetics apparently that causes NMS is metoclopramide. So, scary stuff out there, but just to keep there in the back of our heads. Again, it's not usually due to an overdose, and it's usually you can't find a clinical correlation with serum levels that cause NMS. It's not a dose-related phenomenon, and as I mentioned, can happen after a single dose or after many years of using the same dosage. Exact pathophysiology of why NMS occurs, we don't know, but it's speculated that the blockage of the dopamine receptors in the hypothalamus is what leads to the hyperthermia and dysautonomia, as well as a consequential rigidity and tremors. Another theory is that there's a direct effect on the skeletal muscles. And that's why we sort of go back to the basics here. It all starts from the dopamine antagonism, and then it branches off from there, and it's all the findings that we see clinically in NMS, and we'll break that down quickly as well, just for a differentiation between this and serotonin syndrome. So to help us with diagnosis, unfortunately, unlike SS, there's not a clear-cut criteria. There's multiple criteria, and it's very debatable amongst the psychiatrists. Two major papers out there, and one American Psychiatric Association position, and we're going to stick to their position as sort of the consensus building one, and we'll discuss that right now, and here it is. Essentially, there's 4 symptoms that you should look for, and again, you won't always find them in NMS. The most common ones we look for are fever and rigidity. Rigidity is the most common one as opposed to clonus or hyperreflexia, and this rigidity is generalized, not localized only to the lower extremities. It's found to be diffusely presented, and those are the 2 main findings that they've found. So what they suggest is that whenever you have a clinical suspicion of NMS, if these 2 things are there, fever and rigidity, it should help somewhat, to a certain extent, lead you down that pathway. Then if you obviously have autonomic instability and mental status changes and the history fits, then you go towards this route. And the mental status changes, as always, are usually very vague. And here's this clinical spectrum. So initially they'll usually present with mental status changes, then you'll notice some rigidity, they will start to get febrile, and then the late findings are autonomic dysfunction. Lots of variability exists, so this pattern is not necessarily the way in which you'll present. But apparently in one study, 70% of the cases presented in this fashion, so that's sort of more promising, that there is at least some sort of reason and rhyme to this presentation, but as we all know, in real life, this doesn't really generally happen. And as I mentioned, it's reasonable to consider this diagnosis when 2 of the 4 symptoms are present, when the offending agent is involved. Differential, same differential that we mentioned for SS. They're often misdiagnosed because they fall in the same category. Why differential? And we hit upon all these with serotonin syndrome, so I won't belabor the point there. differences between SS and NMS. Again, serotonin syndrome usually will present in the first 24 hours, within 24 hours. Whereas neuroleptic malignant syndrome is usually a prodrome. It takes some days to sometimes even weeks for the patient to present. The symptoms sort of gradually build up. Neuromuscularly, the findings, as I mentioned, are in serotonin syndrome is tremor, clonus, hyperreflexia, whereas luckily it's usually the opposite. In NMS, there's some bradyreflexia as well as muscle rigidity that's more extreme than occasionally found in serotonin syndrome. Causative agents, as mentioned. And treatment agents, remember, no bromocriptine in serotonin syndrome. That's a no-no. And they usually resolve for serotonin syndrome quite rapidly, usually within a day, whereas NMS, usually it's a more severe presentation. Generally, mostly always go to the ICU or get admitted for sure. And the resolution needs to be monitored over days and weeks. Again, no single test. But in one study, and I did highlight it here somewhere, it was found that low serum iron concentration is commonly seen in NMS patients, and it's 100% sensitive. Why and how they found that out, they didn't really elaborate, but it was found to be the case in this study right here. So something to look into for curiosity's sake. I was going to touch upon Parkinsonian crisis, but just for the interest of time, I won't get into that. Sometime, and you'll know the picture is generally going to be an older person, history of Parkinson's, on long-acting medications for that. So just differentiate that between NMS. Complications of, as I mentioned, NMS is much more severe, unfortunately, the complications as opposed to serotonin syndrome. And they usually relate to a wide spectrum of things. More common to find arrhythmias in NMS, unfortunately cardiomyopathies, DICs, DVTs. Those are the things that we sort of try to prevent in NMS. Management, just to touch upon this briefly as well. Obviously remove the causative agent, maintain cardiorespiratory stability. ABCs and RSI. RSI is more common in NMS as opposed to serotonin syndrome. IV fluids may be needed as well, and an alkalization of the urine depending on how alkalonic they are or if there's acute renal failure, acidotic they are, and prevent any acute renal failure. If they're very, very hyperthermic, we need to use cooling protocols for them, try to lower their BP. And maybe Dave can touch upon this, but I wasn't able to find the literature as to why it's propensity to cause DVD or hypercoagulability in an NMS state. But they advocate using heparin or low-weight molecular heparin to prevent this in NMS. As to why it's more prone to cause this, I couldn't find any literature as to why. But they do mention it as a complication that needs to be prevented. Benzos, again, to control the agitation. And again, dantrolene is something that we use occasionally, not in SS, but maybe used in NMS. And there's sort of the indications and contraindications to use it. Bromocriptine is something that we can actually use in NMS. It's a dopamine agonist, and so that therefore restores the dopaminergic tone that's lost in NMS. So it's something that we can definitely use if we're convinced that the patient has NMS. I'm not going to get into this. Electroconvulsive therapy, that's usually if the patient has not resolved in terms of their presentation for a few days of NMS in the hospital, and they got residual catatonia that's persistent. ECT can be used. Prognosis, like I said, it's a little more protracted course as compared to SS. They need to be admitted. There's a higher rate of mortality, and there is extreme caution in restarting the neuroleptic agents with patients having NMS. Disposition from our end of things, really it's going to be admission, and most probably to the ICU, because they will present not as benignly as serotonin syndrome. Again, the whole point of the topic today in Grand Rounds was this is a very difficult diagnosis to make, and no one's saying that it's very easy at all. Just the main thing is to keep a low level of suspicion when the right picture presents itself, and have the Hunter criteria in your mind, and as well as things that need to be differentiated between NMS and serotonin syndrome. Unfortunately, a lot of things won't present as obvious as this case here, so no one's saying that, you know, if you can't figure out the diagnosis, it's a bad thing. Just be cautious in as to what medications you initially give the patient if you are suspicious of having serotonin syndrome on the differential.